Good morning, everyone. Welcome to Grand Rounds. I'm going to be talking about high ankle sprains today for my Grand Rounds. I have no disclosures to disclose. So a little overview of what we're going to be talking about today. A brief introduction of the topic, review of the relevant anatomy of the syndesmosis and surrounding structures, and then talking about diagnosis and workup. Moving on to treatment options, various fixation methods for surgical treatment of a syndesmotic injury, and then a brief discussion and some take-home points. So just to begin, talking about what a high ankle sprain is. So it consists of injury to the ligamentous structures of the syndesmosis, resulting in stretching or frank disruption of the syndesmotic ligaments. A severe sprain can cause diastasis of the distal tibiofibular joint. Another definition that I found in my research was injuries to the distal tibiofibular syndesmosis, including stable ligamentous injuries and complete unstable syndesmotic injuries with complete ligamentous disruptions with or without an associated fracture. I know frequently we see these with fracture. I'm going to be focusing mostly on today on those that do not involve an ankle fracture. So brief comment about incidence. We'll go into this a little bit more in a little bit. But ankle sprains are among the most common injuries in all of sports medicine. There are reported 2 million ankle sprains per year in the U.S. alone, and they account for 30% of all athletic injuries in total. Syndesmotic injuries are a little bit more rare. As a subset of ankle sprains, they account for 1 to 16% of all ankle sprains. Depending on the literature that you look at, a little bit newer literature looking at specifically athletes puts the incidence more at close to 12% of all ankle sprains. So just a little bit, recently it's been in the media a little bit more because of Alabama starting quarterback Tua. He sustained a high ankle sprain in the fourth quarter of the SEC championship, and then came back to play in the national championship against that small South Carolina school that ended up winning the game. So continuing on, this disruption of the syndesmosis, like I said, can occur with or without fracture. Weber V fibula fractures are associated with around 50% with a syndesmotic injury. Weber C fibulas close to 100%. And after a purely ligamentous injury to the syndesmosis, about 40% of patients still complain of instability at 6 months. So moving on to the relevant anatomy of the syndesmosis, the syndesmotic ligaments, there are 4 of them. The syndesmosis is defined as a fibrous joint where 2 bones are joined by these strong ligaments. So talking about the boundaries of the syndesmosis, starting with the tibia, the proximalmost extent as the lateral ridge of the tibia or the interosseous ridge of the tibia extends down distally towards the ankle joint. At about 8 centimeters above the ankle joint, it bifurcates into an anterior and a posterior ridge. The distalmost portion of these are named. The anterior tubercle is called the Chaput tubercle, and then the posterior tubercle makes up the lateral portion of the posterior malleolus. The fibular portion has a similar ridge, the medial ridge of the fibula, which runs down, and the interosseous ligament connects the 2 bones together there. As it approaches at around the same level, around 6 centimeters, it bifurcates as well. Its anterior tubercle forms the Wagstaff-Lefort tubercle, and then the posterior tubercle, I didn't find an eponym for that one, but it's in the literature it described it as pretty insignificant when compared to the anterior tubercle of the fibula. So these are some CT scans, axial slices through this relevant anatomy that we were just discussing. The top A is just before those lateral ridges, lateral and medial ridge bifurcate. And then B through D is going more distal in the syndesmosis. Notice that the incisura is this concave area that's bordered on anterior and posteriorly by the ridges or the tubercles on the tibia is concave, and the fibular portion of the syndesmosis is congruent with it. There's been some anatomic studies that have described a flatter incisura in about 1/3 of the population, and this will become relevant when we talk about the various radiographic measurements you can look at to determine reduction of the syndesmosis. So the anterior tubercle of the tibia, as you can see, just anterior there on these axial slices, is significantly larger when compared to the posterior tubercle and is the main bony restraint to the fibula for anterior translation. So continuing on with this anatomy, there's a zone that's termed the tibiofibular contact zone that's at the distal end of the syndesmosis. It measures around, on average, 5 to 3 millimeters. It's covered in hyaline cartilage and is continuous with the plafond of the tibia. In the literature that I looked at, they mentioned it as a potential guide to reduction. I don't know how feasible that is because it's so small and it's not always visualized. But this is one thing that's I'd like to stress with this is that this is a true joint. It has articular cartilage and has motion in 3 different planes. So the syndesmotic recess is the next portion of the syndesmosis that I want to talk about. It's also contains something called the posterior fat pad. It's a synovial plica that extends from the ankle joint. It extends from the distalmost aspect of the interosseous ligament, and then it extends up caudally towards up the tibio-talar joint. It attaches to the posterior margin of the inferior transverse ligament, and it can extend as much as 25 millimeters cranially. A clinically relevant portion of this is they mentioned it as a potential spread of infection if there was a K-wire or a syndesmotic screw. It could lead to septic arthritis of the ankle. There was no incidence that I could see quoted of that being relevant, but in the 2 images down there's one sectioning with where they injected intra-articular dye into the ankle, and you can see part of it leaking up through the recess there. 2 is the structure that's labeled 2 is that tibiofibular contact area, and then 3, where any of the green dye that you're visualizing there in between the 2 bones, that's the syndesmotic recess there. So moving on to the syndesmotic ligaments, there's 4 of them. The first one we'll discuss is the AITFL, the anterior-inferior tibiofibular ligament. It's a trapezoid ligament that runs obliquely from the anterior tubercle of the tibia, around 5 millimeters above the joint surface. 20% of it, the distalmost 20%, is intra-articular. It's a multifascicular, and there's an average of 3 bundles in cadaveric studies that I looked at. The middle bundle is considered the strongest and the most clinically relevant. It's the widest and also the thickest of the 3 bundles. In a couple of the studies that I looked at, it was considered the weakest of the 4 syndesmotic ligaments, and tended to be injured the most and fail the earliest with an external rotation stress to the syndesmosis. There's also been described an accessory AITFL or Bassett's ligament that's distal to the AITFL. It's present in about 50% of cadaveric specimens. And this, in the literature, they mentioned it potentially causing impingement if there was chronic inflammation in this area. So here's a specimen there with the tibias on the right, fibulas on the left. Notice the 3 bundles that are present of the AITFL there, and the border between the arrows. And the other one is an MRI axial cut, and you can see the multifascicular appearance of the AITFL there. So continuing on, it's in a landmark study that looked at the strength of each of these ligaments and how much they contributed to the stability of the syndesmosis. AITFL was measured at 35%, but this was from lateral. They sectioned the ligaments and took them out and then stretched them laterally in line with the fibers. It wasn't a very physiologic stress test, and so in more recent literature, where they kept the tibia and the fibula intact and then stressed the ligaments using an external rotation stress, it came to about 24% of the stability of the total syndesmosis. Like I said, this is an oblique ligament that runs obliquely in the coronal and sagittal planes. So then we go on to the PITFL. It's a triangular ligament that has a broad base at its tibial insertion. It is also multifascicular. It's quoted as being much stronger than the AITFL, and this is probably because it's much larger. It averages about 6 millimeters thick and up to 22 millimeters in width at its widest point on the tibia. It can frequently cause an avulsion fracture that you'll see off the posterior malleolus that we frequently see in trimalleolar ankle fractures. The fibers are more horizontal than AITFL, and this also relates to its stability in the syndesmosis. As far as external rotation stress, well, first the lateral traction model is from that older study that I was just talking about. It was said to account for 9% of the syndesmotic stability, which seemed low for such a large ligament. Newer data suggests it's around 15%, and this, once again, this is resistance to external rotation stress is what they're talking about. Here's another sectioning of it. Notice it's broad insertion over the tibia, and its fibers tend to be running a little bit more horizontal than the AITFL. This MR section here of the coronal slice showing the distalmost aspect of the 2 is labeled the distalmost aspect of the PITFL there. So the other 2 ligaments of the syndesmosis are the inferior transverse ligament and the interosseous ligament. So the inferior transverse runs from the distal posterior rim of the tibia to the proximal lip of the fibular malleolar fossa. It's analogous to a labrum in that it deepens the posterior edge of the tibia and plafond. In some literature, it can extend as medial as the medial malleolus. Other places describe this as the intermalleolar ligament. Some literature describe them as the same. Others said they're distinct entities. This has also been described as the deep PITFL, but most sources that I looked at called it the inferior transverse ligament. Accounts for about 33% of the stability of the syndesmosis. And the interosseous ligament accounts for about 22% of the stability. Interosseous ligament is pyramidal in shape. It's a thickening at the distal end of the interosseous membrane. It's been described as functioning as a spring and having some shock absorption in the normal gait cycle. So these are some MR arthrograms. 3 is detailing the inferior transverse ligament. 2 is showing what could potentially be termed the intermalleolar ligament as it blends with the inferior transverse more medial. And then those same structures are being highlighted on the axial cuts here. So just a real quick comment on the physiologic motion of the syndesmosis. Like I said, this is a true joint that has motion in 3 degrees or 3 planes. The normal syndesmosis, it naturally widens with dorsiflexion as the wider part of the talus engages the mortise. Average widening is about 1.25 millimeters. And like I said, the 3 planes that it moves in are distally it can translate 2 millimeters. It rotates about 4 degrees. In that same motion of dorsiflexion, as the larger part of the talus engages the mortise, it widens the syndesmosis and externally rotates the fibula. And then sagittal plane, there can be as much as 3 millimeters of posterior translation. These are ultrasound images demonstrating the top A and B are the AITFL. One is A is in plantar flexion, showing that it's loose in plantar flexion, and B is showing it's tightened, more echogenic in dorsiflexion. And then C and D are the similar results in the PITFL as well. So just a quick summary of the anatomy that we've gone over. Syndesmosis, once again, is a complex joint that has motion in all 3 planes. There are 4 distinct syndesmotic ligaments that make up the syndesmosis. The AITFL is the main restraint to external rotation, but it's also the first to fail in that same in an external rotation moment. Syndesmotic motion is necessary for full ankle range of motion and functioning. All right, moving on here. It's a diagnostic and workup. This study that I looked at was a study looking at commenting on the epidemiology of high ankle sprains. It was NCAA reported injury data. They looked through the database and the years mentioned there. They found that 24.6% of all ankle sprains were syndesmotic injuries that were reported. Once again, this is in athletes, so especially in Football players, this is going to be a higher incidence. They were 14 times more likely to sustain a syndesmotic injury in a game versus a practice. And then 75% of these occurred with some form of contact with another player. And this was one of the pictures that they mentioned as being an incident where there was a high ankle sprain. Running plays had the highest incidence, and then by position, running backs and defensive linemen, which makes sense because they're in contact with other players quite a bit. This was another study I found that was out of Europe. It took high-speed video footage of soccer players that had an MRI confirmed high ankle sprain, and analyzed the mechanism of that. So there are 12 professional players. The oldest athlete was about 23 years old, so these were pretty young athletes. 9 of the 12, their injury occurred with contact with another player, with a dorsiflexion external rotation moment, which makes sense if you think of the anatomy there. As the talus is forced in a dorsiflexion, it's going to widen the syndesmosis, and those ligaments will be stressed. And then 3 of the 12 had a supination inversion with abduction moment. They were all graded on something called the West Point grading system for high ankle sprains, and we'll discuss that in just a second. So this was some footage from that study. Notice the top left with the player in the red jersey. As he takes a tackle from another player, his ankle continues to be dorsiflexed as his body or his tibia externally rotates over the top of that. That was the main mechanism they described, and this seems to be consistent across most of the literature I looked at. All right, this is a simplified version of the West Point grading system that they used. Grade 1 was considered no instability with a partial AITFL tear. Grade 2 was some instability with an AITFL full tear, and then a partial tear of the interosseous ligament. And then grade 3 was a full tear of all the syndesmotic ligaments, and frank diastasis on x-rays. Here's a modified grading system that includes some of the tests that we'll talk about here in just a little bit. And it also includes the deltoid ligament, which is important for surgical management of this injury. So this is a little bit older study that talks about syndesmosis injuries in athletes. They describe the mechanism to be similar to what we have just talked about, to being dorsiflexion and external rotation. They also talk about presentation in these athletes. A lot of times they had anterolateral ankle pain, pain directly over the anterior syndesmosis, over the AITFL. And they describe the pain being more localized than just a simple lateral ankle sprain. In this study, they talked about it being seen more commonly in skiers and rodeo bull riders. Skiers, because as their uphill ski catches, it would force an external rotation moment on that leg, and they're locked in the boot in dorsiflexion. So most of these refuse to bear weight, and that refusal to bear weight was seen more than in just a simple ankle sprain. The best test that they recommended was the external rotation stress test, which is similar to our external rotation stress radiographs. You stabilize the tibia and then externally rotate the foot and ankle while in dorsiflexion. Here are some of the radiographic criteria that they looked at, looking at a normal syndesmosis. So the tibiofibular clear space on an AP was supposed to be less than 6 millimeters. The tibiofibular overlap on the AP was supposed to be greater than 6, and the overlap on a mortise view was supposed to be greater than 1. Now, there were quite a few studies that I looked at that disputed this and said there was quite a few patients, because of a flatter syndesmosis, that had a tibiofibular overlap that was actually 0, or a slight widening of their syndesmosis as well. So these potentially are not the most reliable things to go off of, but they're a good place to start. All right, this is another study I looked at, looking at the NFL Combine. It surveyed players, talking about their injuries. Of these 320 players, 47 had had a previous syndesmotic sprain. So it was consistent with the incidents quoted in the previous study. Defensive backs, defensive line, and O-line were the highest injured. And then QBs notably had the lowest incidence of injury, and they theorized because they had the least contact with other players. And this was definitely an elite group of athletes, and it may not be necessarily applicable to high school or recreational athletes. And also these were self-reported. This was one of the older studies that I looked at that looked at over 1,000 ankle sprains at West Point. It was following up to a previous study that established this, the grading system called the West Point grading system. They quoted only 15 syndesmotic injuries, which seemed to be extremely low, and recent literature has shown that to be more. The important thing here is that of those 15, most of the X-rays were normal, with no syndesmotic widening, and only one had a positive external rotation stress radiograph, and then another one had a frank diastasis on presentation. They also recommended the squeeze test. They said all 15 of their patients were positive with the squeeze test. It's putting pressure, stressing the syndesmosis through squeezing the tibia and the fibula together, more proximal to the syndesmosis. And they also theorized that frank diastasis without fracture was pretty rare. All right, this is looking at some different tests available to us. This study was comparing confirmed MRI syndesmotic injuries with clinical diagnosis. And you can see the sensitivity and specificity there. The external rotation stress test was actually a little bit less sensitive and specific than just the squeeze test alone. And they recommended using a combination of these tests. It tended to increase the sensitivity of the diagnosis. Deltoid ligament notably was also injured in 2 of 10 patients in this group. This is another MRI-based study, where they looked at 43 patients who had had a syndesmotic injury, and looked at the presentation of these patients. 94% had lateral ankle tenderness, 64% had proximal tenderness that extended greater than 5 centimeters up the syndesmosis. And in this study, they proposed an MRI grading system that I have on the next slide. But of those, all of their grade 4 injuries were season-ending injuries. So this is their MRI-based study. It's a little bit different than the previous grading systems that we talked about. It adds in the deltoid ligament at a grade 4, and this is once again based off of the MRI. Notice on the right, the table on the right shows a lot of the concomitant injuries that they had, bony contusions and chondral defects being included. Medial tenderness was also included in this, and you can see the amount of time missed. The average missed games obviously got more as the grade got higher, but they quoted around 20 days was the number of missed practices that they normally, on average, found. This is another study looking at some more of the tests that are available to us. The important thing here was as they looked at quite a few different tests, and they also compared it to the presentation radiographs. Interestingly enough, they didn't perform stress radiographs because at their institution in Iran, they said it would require general anesthesia, which is interesting. We always do stress radiographs without anesthesia in the ER. But of the diagnostic tests that they went over, the most sensitive and specific was the cross-leg test, which was described on the previous slide. You place the injured leg over the contralateral knee and place a downward directed force on the knee, and then stresses the syndesmosis. Positive test would be pain at the anterior syndesmosis there. Radiography had a low sensitivity, mainly because there was just one patient that had diastasis on their original presenting X-rays. And finally, for this, I looked at a systematic review that went over all of these different tests. The takeaway from this is they looked at 114 articles. It was a pretty thorough review of diagnostic workup for high ankle sprains. Their most reliable tests that they found were the cont'd stress test. A little bit different than the intraoperative cont'd tests, where they stabilized the tibia, and then they directed a lateralizing force to the fibula in the office. And I hadn't observed that test before, but they said that it was on par with external rotation stress test and the squeeze test as well. Bottom line of this study was that they recommended using a combination of these, and that no one single test had a very good diagnostic accuracy. So just a quick summary of these diagnostic workup and tests. Mechanism is predominantly seen as a dorsiflexion external rotation. If the deltoid ligament is incompetent or injured, it can also include a supination and abduction mechanism that can produce this injury. High-impact sports like football are more likely to see this injury. They're going to present with tenderness of a syndesmosis, inability to bear weight, and continued pain, and a subjective history of instability can also be kind of a red flag for potential high ankle sprain in athletes. The screening tests that were recommended was the squeeze test, cont'd test, external rotation stress test, and the cross leg. Of note in the literature, most of these presenting x-rays were normal, AP and mortise of the ankle. I did not see much literature talking about an external rotation stress test. I thought this could potentially be something that could be investigated. MRI is once again the gold standard for diagnosis, and it's normally the go-to in most of the literature I looked at. All right, so moving on to treatment here. One of the study that I looked at that was done in 2007, it described a 3-phase clinical rehabilitation protocol for non-operative management. They sectioned it into acute, subacute, and then a reintegration into sport. And they did note in this study that they were rarely able to ambulate, and so they kept them non-weight bearing for the acute phase. And I'll go into a little bit more detail of their protocol here in a second with this next study. So this was another study that the previous one actually had cited that was talking about 60 NCAA athletes that were treated over a 3-year period. It was a prospective study. They were all diagnosed clinically within 24 hours with a high ankle sprain. It was predominantly men in this study. Interestingly, it occurred while a good percentage of them were wearing some sort of protective device like a brace or ankle taping or both. And these, contrary to other studies, these occurred mostly in practice. They measured the extent of tenderness up the interosseous ligament and correlated that with missed time from practice and games. And they were splinted and kept non-weight bearing for 4 days. This was their protocol. They talked about the acute, subacute, and then the reintegration into sport. Like I said, they kept them non-weight bearing for the first 4. They progressed them on to partial weight bearing with a brace that they could come out of for resistive exercises and stretching. And then they had them full weight bearing by 6 days. So one thing of note in this study, I thought that most of these injuries had to have been a lower grade of injury because many of these patients were able to return to sport within 14 to 21 days. And they were able to pass these functional tests like 15 single leg hops. So this is, in a severely injured high syndesmotic sprain, I don't think that these patients would be able to return as fast. So this is just more about that study. 13 days was the average time that they were off. And they said that they could predict the amount of time lost by the extent of the tenderness in the syndesmosis. So the average height was 8 centimeters. Anything above that correlated with a higher time off. They termed this to be conservative aggressive treatment. And like I said, these are all likely low-grade injuries. So this is another study looking at conservative treatment, or looking at both, but their conservative arm, they looked at 143 ankles. These were all professional athletes. The non-operative management, they averaged a time of 3 to 6 weeks that they kept them non-weight bearing, the longest being 6 weeks there. And then in some studies like the previous one, they only kept them non-weight bearing for a couple of days. Some of the treatment regimens that were discussed in this study was corticosteroid injections, taping, whirlpool therapy, NSAIDs, and then proprioceptive training. In this study, it was a little bit longer. It was about 23 days before they were able to go back to full activity. And their rate of complication they found was pretty high. It was 68%. It included stiffness, pain with activity, limp, HO formation, which was also noted in previous studies. and then residual instability, which was noted in one patient. All right. Moving on to the surgical treatment. This arm of this study specifically looked at 16 patients that were treated surgically. Their surgical indications that they came across was syndesmotic injury with deltoid ligament injury as well. Taylor shift with any fibular fracture, or without fibular fracture. And then syndesmotic sprain without deltoid ligament normally was managed non-operatively, and this is what they found in this literature. So some of the surgical technique that they discussed was K-wire fixation or screw fixation. They specifically used 4.5 millimeter quadricortical screw fixation, and these patients were kept non-weight bearing for at least 3 weeks after surgery. And most of the literature that I looked at, and this study included, they removed the syndesmotic screw at close to 3 months postoperatively in most patients. This is one method of fixation that I came across in the literature that had a lot of literature in Sweden, and I couldn't find anything significant here in the United States. It's called the Syndel method. They use a cerclage wire to reduce the fibular fracture and then staple the syndesmosis, as you can see on the radiographs on the right there. So this was a series of 347 ankle fractures. Retrospective study that looked at these Weber B fibular fractures that had syndesmotic injury. Syndel method, like I said, is used, what I could find, mainly in Sweden. And their points were there was a cheaper construct that it reduced the cost by almost 50%, and that there ended up being less reoperations for hardware extraction as well. Some other options for fixation that were discussed in the literature was bioabsorbable screws. This is a cadaveric study that looked at the biomechanical equivalency of the two. They compared a 5 millimeter bioabsorbable screw with a 5 millimeter cannulated stainless screw, so a pretty large screw in both cases. And they were found to be, after 1,000 load cycles of the cadaveric specimen, they were found to be equivalent. This next study that looking at the bioabsorbable screw that was used in patients, it was a meta-analysis of 3 randomized controlled trials and 1 retrospective review. There were 137 patients that had the bioabsorbable screw. These were the implants that they used, a 4.5 millimeter PLLA bioabsorbable screw versus a 4.5 millimeter stainless, and quadricortical, and then the 3.2 millimeters that they reviewed were tricortical. So in this study, like I said, as seemed to be consistent in a lot of the literature, all the screws were removed at 3 to 4 months postoperatively. They claim no statistical difference between the bioabsorbable and the metallic screw in their level of complications. However, I think this was clinically significant because 1 in 4 of the patients that had the bioabsorbable screw had some type of wound problem, whether that was a tissue reaction or a wound dehiscence. So I think that this was actually clinically relevant here. There was no loss of fixation that was noted in either of these groups. So the next study that I looked at was a comparison for screw fixation and suture button, which is another technique that was mentioned in the literature. Specifically, this was a Korean study that looked at 20 patients who had been fixed with an Arthrex tightrope fixation versus a screw fixation. Their indications for fixation was a movement of greater than 3 millimeters in a intraoperative cotton test, a tibiofibular clear space that was greater than 6 millimeters on their radiographs, tibiofibular overlap that was less than 6 millimeters, and a medial clear space that was greater than 4 millimeters on a stress. So the screw fixation group was 3.5 millimeter screws. They were tricortical, and then both the screw and the button were placed between 2 and 6 centimeters from the tibial plafond. The suture button and the screw, there's just a note on technique here, they were directed anteriorly at 25 degrees from the posterior lateral border of the fibula, which is the axis of the syndesmosis. And the syndesmotic reduction was obtained using a clamp. So this is a diagram of the Arthrex tightrope system, which I'm sure most of you are familiar with. The suture button uses a 3.5 millimeter drill bit. All of these patients were kept non-weight bearing initially after surgery. Interestingly enough, they let the suture button group weight bear at 6 weeks versus 8 weeks for the screw group, and they didn't comment on why. They just said that they were able to allow them to weight bear at 6 weeks. 5 patients in the middle screw had the screw break, and they considered this a complication. And the radiologic evidence of reduction was equivalent across both groups. And then their outcomes, functional outcomes, stiffness, pain scores were also equivalent after 1 year of follow-up. So the next study here is looking at the similar study comparing, this one was done actually in Germany and was recently published in 2018. It followed 4 patients. It was a randomized controlled trial that followed them up to 1 year. There was comparing the newest Arthrex tightrope system, which is a knotless system, to screw fixation. Both the groups were similarly distributed. They were randomized, and they were a mix of both pure syndesmotic injuries and ankle fractures with syndesmotic injury. The majority of them were just pure high ankle sprains, grade 2 or grade 3. And then the ankle fractures that were included were a couple Weber B per group, about 4 or 5, and then a couple Weber C as well, fibular fractures. So they also mentioned that they use intraoperative, a 3D intraoperative fluoroscopy, I think similar to a 3D CT scan, that they use to gain a better reduction of the syndesmosis. The tightrope and the screw were placed at about the same height from the plafond, 3.5 centimeters above it. And both groups were kept non-weight bearing for 7 weeks following surgery. So on their follow-up, they used the Foot and Ankle Disability Index, the AOFS-A, and then a myriad of other surveys that they used to determine pain scores and functional ability. They found no difference at any level of follow-up. They followed them every 2 months out until 6, and then they had a 1-year follow-up after that. The tightrope patients were able to return to work 2 weeks earlier, 9 versus 11 weeks in the metallic screw fixation group, and then return to sports was on average for the tightrope was 14 weeks and 19 for the screw group. They did know that one of the suture button implants was removed at 3 months because of local tissue irritation, and they opted to remove the screws in all of the patients as well.
Medially or laterally?
Lateral tissue irritation. That's what they said. So just a summary of the fixation methods that are available. Like I said, there are a lot of available options. Metal screw fixation is the traditional method. Bioabsorbable screws, staples, and then suture button being the newer of the constructs. Because of the overall higher rate of complications of the bioabsorbable screws, even though there was a promise with them and they're shown to be biomechanically equivalent, it's recommended in at least most of the literature I read to avoid the use of these bioabsorbable screws for syndesmotic fixation. So like I said, the traditional method is the metal screw. It's a rigid construct that might potentially necessitate screw removal at a later date. A lot of studies mentioned complications being hardware failure, but I know that this could potentially be seen as a desired result because it allows the syndesmosis then to regain its full range of motion at a later date, and also signifies that the fracture, if there's a fracture, is healed at that point. HO was also quoted as a complication, but it was seen in not just the screw fixation group, it was seen in non-operative management as well. It's a documented complication of syndesmotic injury, hardware irritation, and then stiffness. So the suture button is, like I said, is the newer implant. It's been shown to be biomechanically equivalent. It theoretically allows for more physiologic motion of the joint, and it's definitely a lot more expensive than a single or double screw construct. The Erlanger has their contract with Arthrex allows them to get it for $880 for a single suture button. If you use that was pictured earlier, there was a dual hole buttress plate that Arthrex recommends for heavier patients. over 250 pounds, I believe, it goes for $2,350 for the whole kit itself. So significant costs there. There's also a theoretical benefit allowing not just the motion, but it can account for malreduction of the syndesmosis because of that motion. Theoretically, it could help reduce it as the patient is able to move more through their range of motion. So some complications that were unique to the tightrope was entrapment of the tibialis anterior that was noted in a couple studies, aseptic osteolysis at a much lower rate than the bioabsorbable screws, and knot prominence, which the newest generation of the Arthrex tightrope is a knotless construct. So just an important note about reduction of the syndesmosis. So malreduction has been documented to cause post-traumatic arthritis. There is hyaline cartilage there. It can also cause stiffness and poor functional outcomes at long-term follow-up. In one study that I looked at, there was malreduction in as high as 52% of cases. It wasn't adequately reduced in the incisura. And this was just with closed reduction and fluoroscopy. But even under direct visualization, I noted there was one study that noted as high as 15% of malreduction, and this was conserved with a postoperative CT scan. In both of these studies, they recommended at the very least using CT potentially postoperatively, or if it was available, using it intraoperatively. One thing there is that it seems to be quite expensive, and something that is added time to the surgery, added anesthesia time. And I don't know if it's exactly warranted if you're able to obtain an open reduction there. And then one study looking at the different measurements that we've discussed, the tibiofibular overlap, medial clear space, etc., noted that some of these can be inaccurate, mostly because patients' anatomy can be, there can be huge differences in anatomy. The incisura can be extremely flat in a third of patients, like I discussed, and that can predispose to a tibiofibular overlap that's zero, or that can even be slight widening of the syndesmosis that's natural in these patients. So they recommended at the very least contralateral x-rays intraoperatively to compare your reduction to. This is a CT scan and intraoperative CT scan and fluoroscopy that was noted in one of the above studies that was demonstrating a reduction on the mortise view there of the syndesmosis. Then with the CT scan, it showed that it was malreduced, and they removed the K-wire, re-reduced it. There's a CT scan demonstrating the improved reduction and then fixation with 2 stainless steel screws. So some of the surgical, just in summary, some of the surgical indications for high ankle sprains that I came across in the literature. Normally grade 1 sprains, which is an isolated AITFL, and this is going off the West Point grading system, can be managed non-operatively. You give them a period of immobilization for the acute period, and then can be advanced with any type of PT protocol that's surgeon dependent, but aggressive stressing and gentle exercises, and then an early return to sport, it was recommended as well. Grade 2 injuries are kind of the gray zone. There's depending on the extent of injury, so with a competent PITFL and deltoid ligament, these normally can be managed non-operatively. But if under, these authors recommended if there was MRI evidence of either of those, a PITFL injury or a deltoid disruption, then a fluoroscopic exam or arthroscopic exam was recommended. And on arthroscopy, they recommended greater than 2 millimeters of syndesmotic widening, or alternatively, you could use a 3.5 millimeter shaver head, and if it fit into the syndesmosis, then they considered that to be a positive finding for instability and an indication to fix it. Or failed non-operative treatment of grade 2 injuries. If these patients continue to have pain and instability, then it was recommended that they be fixed as well. Any fracture of the fibula with syndesmotic instability was an indication for syndesmotic fixation, as demonstrated by medial clear space widening or increase in the tibiofibular distance. And these were normally done on stress radiographs intraoperatively, using either cont'd test or the external rotation stress test. So here's the arthroscopic images on the top, demonstrating their trick of using a 3.5 millimeter shaver to demonstrate syndesmotic widening. And then on the bottom, showing A is a normal syndesmosis, B is what they termed a stable syndesmotic injury, and C is unstable. And then for them, a grade 3 ligament, or grade 3, one was extremely rare to be purely ligamentous, and any grade 3 was treated surgically. This is a disruption of all or most of the syndesmotic ligaments with or without a deltoid ligament injury. So just some take-home points here. So high ankle sprains are relatively rare in the general population, and they're going to be more common in contact sports, and athletes in general are going to have a higher incidence. Early diagnosis and treatment are going to be key to obtaining better functional outcomes in these patients. Going through the literature, I think a low threshold for MRI in these patients with suspected injury is important. It's going to be your diagnostic test of choice there. I think all of the grade 1 and a large portion of grade 2 can be managed non-operatively with physical therapy. I think the thing that was stressed in the literature there was the importance of early range of motion and stretching, and then exercises as well, strengthening exercises, proprioceptive training. Grade 2 injuries with deltoid injury specifically should be treated surgically, and then all of grade 3 injuries should be treated surgically. They also recommended, seemed to be the consensus in the literature that an open reduction was preferable to closed reduction, mainly because of the consequences of malreduction can be severe on your outcomes for that patient, and potentially using CT scan. Like I said before, the intraoperative CT scan potentially is a larger expense and may not be warranted in all patients, but it was recommended by quite a few authors. And I think fixation, whether that's the two most common in the United States, the syndesmotic screw using a stainless steel screw, or suture button fixation, should be case-by-case basis, decision with the surgeon and the patient. Just because the suture button, it has theoretical benefits, but it's also extremely expensive, and the outcomes are equivalent in a lot of studies with the syndesmotic screw. So, concluded. Yes, sir. Okay. Yes, sir. So he was, I didn't find any specifics of the exact grade of his injury, but I believe they just termed it a syndesmotic injury, and he was given the suture button and then returned to play within 2 to 3 weeks after that. Like I said, I didn't come across any specifics of what grade of injury he had. Maybe, yeah, maybe. And then, as far as the MRI, at least from what I read, it was to kind of ferret out which cases had a deltoid ligament injury, or if they were more extensive injuries than just physical exam alone. The stress radiographs on a significant amount of these patients are going to be normal, even if they have a grade 2 injury. I guess theoretically, if the deltoid was out, then you would see medial clear space widening. But I didn't see really good indications why in the literature. Why not just jump straight to arthroscopy or fluoroscopy there? Okay.
Are you going to scope all of yours?
No, I don't think so.